Hi everyone, this is Dr. VYAWAHARE from Amaravati. I am sharing my experience of cataract surgery in nanophthalmic eye. This 45-year-old female presented to me with high hypermetropia of plus 15 diopter with a raised intraocular pressure with medications. She has been underwent a yak peripheral areectomy and she has diagnosed as a case of chronic angle closure glaucoma. Her axial length is around 15.26 mm. Her K1 is of 56, K2 is of 58. Her ACD is only 2.12, and IL power by SRKT is around 47.42, and by Barrett is of 63 diopter. So this is a typical patient of nanophthalmos, and these patients have a crowded anterior chamber, a small anterior portion or as well as posterior portion of the eye. While doing the capsulorhexis, I am using a cohesive viscoelastic to deepen the anterior chamber, and her capsules are very thin and fragile and elastic. So I am doing a slow motion capsulorhexis here. After finishing the capsulorhexis, I found that her iris is prolapsing through the main incision. I am using a cohesive viscoelastic to put the iris back into the anterior chamber. At this point of time, her intraocular pressure was okay. As her nucleus was very soft, there was no difficulty while aspirating the nucleus by the phaco probe. I needed a very little phaco power and the nucleus is aspirated very easily. As you all know, these eyes are prone to have a fluid misdirection. So as soon as I finished my phacoing, I found that her iris is coming through the main incision again and again. After repositing the iris with the help of iris spatula, I could note that her eye has become very tense, and it was really difficult to put the iris back even with the cohesive viscoelastic. So when I check the eye, then I found the eye is stony hard. So continuing the surgery at this point of time would have created a lot of complications. So I have decided to stop the surgery. I removed the speculum and decided to give IV mannitol, and after waiting for around 2 hours, the patient was shifted again in the OR. To begin with, the eye was not very hard. I could start the cortical aspiration, but once I started irrigation on, I noted that the eye had become hard again. So till this point of time, the patient was under topical anesthesia. So I have decided to do the vitrectomy, and for that I will need anesthesia. So I have given her a posterior subtenon anesthesia, and I have injected a trocar and cannula from the pars plana. These eyes have a crowded anterior chamber, so there is a very little space for the maneuvering, and also they are prone for the fluid misdirection and the choroidal effusion. So we have to prepare for vitrectomy or a sclerotomy beforehand. So here I have decided to do a vitrectomy, and after removing the sufficient amount of vitreous, I could finish the cortical aspiration. But after doing the cortical aspiration again, because of the fluid misdirection, the eye have become hard again. As vitrectomy cannula along with the port is in situ, we can remove any amount of vitreous we want to create the space into the anterior chamber for subsequent insertion of the intraocular lens. So this is the second time I am doing the vitrectomy. After removing the vitreous, I am implanting the 60 diopter intraocular lens from AIOC2022, and you can note that there is a disparity between the size of the lens and the size of the eye. Because of the small size of the eye, a small capsulorhexis and a very elastic capsule, I had difficulty while putting the intraocular lens inside the capsular bag. So I have to do a few manipulations, have to struggle to put the trailing haptic into the capsular bag. But with the help of patience, a high cohesive viscoelastic, I could put the leading haptic inside the capsular bag. Even after doing so much of vitrectomy, I was still hard and there was a very little space into the anterior chamber. After doing the intraocular implantation, when I tried to put air inside the anterior chamber, it was not retaining, so I have to remove the vitreous again by the vitrectomy. And after removing the vitreous by the vitrectomy, I could form the anterior chamber, and after that I have removed the cannula and closed the sclerotomy wound. Thank you so much for watching.